All right, we are going to go ahead and get started with the second in our series of webinars as a lead up to WHA. These are known as our policy scrums, and I'll provide a definition of that as I go through our introduction. But again, this is Lois from the Global Health Council, just welcoming everyone who's joined us. For today, following some brief remarks from me, we'll hear from a couple of people who are going to speak to the issue of health system strengthening from a couple of different angles. First, we have Ashley Arbasati from Management Sciences for Health, who's going to talk about global health security and the WHA agenda and specific asks she has for the community leading into and even on site at WHA. And then we'll be hearing from Crystal Lander at Living Goods around UHC and specifically financing for universal health coverage. Again, a major theme of this year's World Health Assembly and an important topic for, I think, a lot of people in our community. At the very end, Liz is going to provide some additional updates on WHA for those of you who might not have received those already, and then let us know about upcoming webinars as part of this series. But the series, again, really came out of the thinking that it would be really important for those of us who are attending WHA in particular to feel equipped with knowledge around certain action items and recommendations that people might have going into the World Health Assembly. As people know, it's a very important time for our community to be able to liaise with ministers of health and other leaders of global health from various countries around the world. And given their agenda, we wanted to pinpoint a couple of items on that that the global health community could really rally around. And so when it comes to strengthening health systems, we're hoping each of the speakers can speak to their topics and provide information as it relates to the upcoming discussions at WHA, but even more importantly, present calls to action for us as we're going to Geneva that we can perhaps echo throughout the GHC delegation and even beyond to other partners who might be engaging in other ways. So the scrums, as we put them together, they started with a webinar a couple of weeks ago around civil society and how we could engage better with WHO. We heard from our vice chair their process as part of the civil society task team to provide recommendations to WHO regarding their engagement of CSOs. And again, we received a call to action from them, first and foremost, regarding how we could weigh in and otherwise inform their recommendations, and then how we engage with WHO at WHA and beyond. And as I said, this session will be focused on health systems. The following sessions in our series will focus on integrated health issues. And then finally, what we usually do is have a conversation with members of the U.S. delegation about their priorities and again, how they might be weighing in Geneva and how we could inform or otherwise support that. So that's an overview of our policy scrums. Next, I think I wanted to provide a bit of background on WHA itself and people a sense of what to expect for those of you who might still be new to WHA. Again, it's an opportunity for member states or representatives of the UN member states to come together and talk about the world's health issues, and in particular, really drill down on the priorities of WHO. Of course, there are a number of events, both official and otherwise, that take place on the margins of those discussions. There are other ways that the community, or specifically members of civil society and other non-state actors can weigh in as well, including by providing official statements and otherwise sitting down with those representatives on our respective priorities. To find more information on WHA, you can access that online. We've included the link here in the slides, and we'll be circulating these slides following this webinar so that you can find those links yet again. But we won't spend too much time on what happens at WHA, knowing that we've offered this background before. But again, we like to do that for each webinar in case we have anyone new joining us. Next, we wanted to be sure that people who haven't joined us before know how to engage as part of this conversation. As I said, we'll be hearing from a couple of speakers, but we absolutely invite questions, and we'll be taking those towards the end. And so if you'd like to ask a question, we ask that you use the chat box to the right of your screen and go ahead and type in your name, your organization, and whatever you'd like to ask, and perhaps to whom, so that we can direct that accordingly when the time comes. With that, I think I wanted to, before we pass things on to Ashley at Management Sciences for Health, we thought it would be helpful for both of our speakers to understand who on the webinar will actually be attending WHA this year. And so we actually set up a quick poll for you all, and we'd like for you to go ahead and participate in this poll, those of you who have joined us. And so you can, this is interactive, so you should be able to click on yes, no, or maybe in terms of whether or not you think you'll be in Geneva next month for WHA. If you can go ahead and do so, that would be great. And we'll be pulling up the results here shortly for you. Okay, so it looks like a third of folks will actually be at WHA with with another quarter on the fence, and a good chunk of people actually won't be there this year. So hopefully it'll be helpful for you to hear from the speakers kind of what will be happening on the ground, so you feel like you're in the room without being there. And we'd love to hear in particular from you any questions you have or ways that you'd like to receive more information about what's happening on the ground, given those of us who will be going and those of us who might need to remain home for whatever reason. But we'll try to tailor our comments accordingly, keeping in mind that not everybody will be on the ground, but certainly want to ensure everyone has a good grasp of the issues we're trying to cover today. And again, the call to action for our community. So with that, I'd like to turn the floor over to Ashley at MSH to touch on strengthening health systems as that relates to global health security. Ashley, thanks for joining us. Go ahead.
Hi, Lois. Thank you so much. And thank you to Global Health Council for organizing and inviting me to be a panelist on health security. A little bit of background. As Lois said, my name is Ashley Arbasati from Management Sciences for Health. I'm the Health Security Advisor, and I'm also the chair of the Global Health Security Agenda Consortium, which I'll touch on in a minute. We can go to the first slide, and I wanted to provide some context before I get into these slides. Infectious disease outbreak costs the world about $60 billion a year, which equals the cost of wars and natural disasters in the terms of economic impact and lives lost. And why that's important is that we are working, countries need to be better prepared to be able to prevent, detect, and respond to infectious disease outbreaks. A virus can make its way from rural China to LA in 15 hours or less. And as you know, viruses don't need passports or pass through border control. We need to bolster U.S. and international health security efforts by investing as a presidential initiative designed to prevent, detect, and respond to infectious disease threats, whether natural, man-made, accidental, or intentional. So that sounds a little bit scary because it has a biosafety, biosecurity, bioterrorism aspect to it. It was essentially designed to help countries reach compliance with the international health regulations, which were updated in 2005 as a result of countries' unreadiness to fight things like avian influenza and SARS. So the thought process behind Global Health Security Agenda is essentially strengthening the system to be better able to respond quickly, stop outbreaks at the source, and invest in preparedness measures through a One Health approach. So if you see this slide in front of you, you can see some of the multilateral institutions that are involved in the Global Health Security Agenda. What's important to note that This now counts in its membership over 60 countries who have signed up voluntarily to undergo a process known as a joint external evaluation that measures countries' readiness along those prevent, detect, and respond, and gives it an actual grade of red as in very underprepared, a lot of needs still need to be met. Yellow, which means progress is being made, or green is that the country has good systems in place that are capable of detecting an outbreak quickly and stopping it. So the One Health approach comes in with these multilateral institutions that act as advisors to the global health security agenda. You see the WHO counts among it the International Health Regulations, the UN Food and Agriculture Organization, or FAO, and the World Organization for Animal Health, or OIE, which counts its regulations as a performance of veterinary systems. Next slide. So this is a kind of dated slide, but it shows the architecture of the global health security agenda. You can see to the right that advisor slot of the previous slide of WHO, FAO, and OIE. At the top of the chain are the ministers of health at the country level, and then a GHSA steering group, which is comprised of 10 countries who are leading the steering group. They have a secretariat which advises overall on progress to date along the GHSA towards these action packages. And you see that they're separated into 3 categories: prevent, detect, and respond. And each of these pillars include specific activities and metrics and measurements. So antimicrobial resistance, biosafety, biosecurity, zoonotic diseases, national systems, emergency operations center. And if you look at the top left, you'll see that there's a box called the JEE Alliance. And you can go to the next slide. Sorry, next slide. Well, I can talk a little while we're flipping through the PowerPoint or trying to do some technical adjustments. The JEE Alliance Advisory Board is a group of advisors that help to at the moment, 68 members, countries, and civil society, private sector organizations belong to the JEE Alliance. I see the next slide is coming up, which we will touch on the stakeholders in this slide, but I will keep going at the moment because that first box at the top is the JEE Alliance Advisory Board. So as I said, it's a multi-sectoral platform. It's separate but still connected to the global health security agenda. Other stakeholder groups are the GHSA steering group, that group of 10 countries that are in charge of leading the GHSA and carrying it forward into 2024. The advisors, which I mentioned before, WHO, FAO, and OIE. Then there's also an interest in health security for the G7 and G20 that the civil society community has been working to make sure that our recommendations are heard. And lastly, there's a big civil society presence in health security, which has been fantastic. And I will talk a little bit about the Global Health Security Agenda Consortium, which was started in 2014 under the stewardship of Ambassador Bonnie Jenkins and the Department of State, when they recognized a need for non-governmental stakeholders' perspectives on the health security agenda, raising awareness of issues and providing an opportunity for multi-sectoral stakeholders that were outside of US government. What the Global Health Security Agenda Consortium does is primarily act as a resource for USG leadership, but also to the international architecture as well, with seats on the JEE Alliance Advisory Board and the steering group. So in addition to the GHSAC, we have the Global Health Council, the Private Sector Roundtable, which is a group of private sector businesses that have organized themselves. Their membership includes companies like GE, Johnson & Johnson, Coca-Cola, FedEx, Henry Schein, and others. They have organized around their own priorities and helping the private sector organize around response since Ebola had such a big impact on the private sector as well. There's also the Coalition for Epidemic Preparedness Innovation, or CEPI, which is funded to help fast track 7 vaccines, the development of 7 vaccines that don't have market potential. So for example, an Ebola vaccine is never going to make a pharmaceutical company money, but it's just a good thing to have given Ebola is highly pathogenic and very virulent. So some of the diseases that they're working on vaccines for are Lassa fever and Nipah, as well as MERS-CoV. The last 2 groups, the C7, C20 working group, which I touched on, which helps provide recommendations to the G7, G20, and the next generation network of young health security professionals. So next slide. So we have some top line comments or top line recommendations that we like to use when we're speaking with either USG, Congress, or externally through international settings. And essentially, this is the case for investment in global health security and why we need to continue leadership in the GHSA through 2024, which has already been agreed upon and is carrying forward at the moment, but I'll touch on that in a slide or two. Essentially, pandemics can kill millions and cost billions, and they cause political and economic instability. We understand that weak health systems threaten economic growth. When one country isn't prepared, all countries aren't prepared, and stopping epidemics at the source should remain at the top of the agenda for heads of state. Just to give you an idea of the cost of preparedness versus response, preparedness plans cost about less than $1 per person per year. If we invest in those, then we perhaps don't have to launch such large responses when things like Ebola happens. We deploy the US military to Sierra Leone and Liberia at huge cost to the US. We believe that it's better spent investing in health systems strengthening through the health security agenda. So next slide. So just a piece of background information that these slides are lovingly borrowed from a GHSA steering group meeting in collaboration with our partners under the consortium with Nuclear Threats Initiative. They did a fantastic job. So some of these you can see are high-level achievements of the health security agenda. If you take it in context of how young the agenda really is, what we've been able to achieve in about 4 years is absolutely incredible. Getting 70 countries to sign up voluntarily. Over 65 of those have undergone this joint external evaluation process. There's been an agreed upon global set of metrics and an appropriate process for beginning to achieve IHR compliance. We're already reaping the benefits of response systems and event-based surveillance. An outbreak in Cameroon was shortened from days or weeks to a matter of hours, which is a huge gain and a huge win. And the fact that the fact that we're really mobilizing the private sector and civil society along with the next generation of young health security professionals is really a huge accomplishment. So next slide. So as I said before, there was a commitment to extending the global health security agenda that was agreed upon at the recent Kampala ministerial, and the ministerials happen once a year where all of the ministers of health, ministers of finance, country delegations come together to discuss success stories, next steps, and do work on action packages in a face-to-face setting. The US and others have also committed support to GHSA 2024. What's happening now is that the GHSA steering group and also the US through HHS is working on submitting comments and developing the framework of GHSA through 2024. Civil society had the ability to provide consolidated comments back on the framework as well as top line comments. We have those in case anybody is interested on what we were, where our focus is. And of course, more work still needs to be done about costing and financing for national action plans, and then of course, actual implementation of programs that will work to close those gaps at country level. Oh, next slide. So this is a little overview of the GHSA 2024 from the Italian leadership who are currently leading the GHSA steering group. They're really looking to incorporate feedback from all of the relevant stakeholders, including the advisors, non-governmental stakeholders, including the GHSAC, and linking into other relevant initiatives, of which there are several operating within this space. But it's still commitment to those strategic objectives, strengthening accountability, that One Health approach, which joins animal and human health together, which the WHO and the OIE with their IHRs and the PVS system, and developing tools and lessons learned. So it's a very exciting time for health security. The work will continue on this framework at WHA, and there's a timeline for rollout and adoption that's coming in later 2018. So next slide. So civil society has issued recommendations for the next phase of global health security. These are some of our top line comments. We work in coordination with other groups, including Global Health Council, private sector, Global Health Technologies Coalition, and the Global Health Security Agenda. We have submitted these recommendations to the Global Health Security Agenda Steering Group, as well as to the Italian chair with our updated recommendations on that 2024 framework. So next slide. And we frequently work together with Global Health Council to provide recommendations where health security or infectious disease epidemic preparedness is listed on the agenda. This is the recent civil society recommendations, the 142nd Executive Board meeting in Geneva, where we try and represent all of our membership base. So you see that we have antimicrobial resistance, we have research and development, to really represent who we are as a group of civil society organizations. Next slide. So this, I'm sorry that this is a little bit slow and coming up, this just gives you the broader context of where we see health security. If you click one more, there should be a yes, there we go. How we hope health security will be integrated into the larger discussion, where we see health systems strengthening as it contributes to UHC and overall the Sustainable Development Goals. And I think there's the last slide. And this is what we're doing around this WHA specifically. We're holding a side event on the margins of the WHA on Monday evening, talking about how the health security agenda contributes to progress on UHC and the Sustainable Development Goals. At the moment, we have opening remarks made by former CDC Director Tom Frieden, hopefully to put into context where global health security fits and some of the gaps and barriers that still need to be overcome. And the last slide. So I know that I ran through a lot of information. Thank you for allowing me to speak and do a little bit of background on health security and what we're doing at WHA to raise issues and provide those recommendations on moving this forward. And I look forward to your questions.
Thanks, very much, Ashley. Really appreciate that, and apologies for the slow slide advancement in terms of our speed here, but we'll motor through the next round with Crystal. I do think that was a lot of really helpful information for the group, and for those who might have joined us late. We're moving on to our second speaker of the day, our second and final speaker around the topic of strengthening health systems. We have Crystal Lander, who's going to talk about UHC and financing, the financing agenda for UHC, and we'll be sharing some priorities as she sees it from Living Goods for the community around World Health Assembly and our call to action. Crystal.
Great. Thanks so much, Lois, and thanks for Ashley for great information to kick us off. So I'm going to start with a little bit of telling you who Living Goods is, because many of you may not know. WHA is always a very exciting time for me because it's a great opportunity to work with your colleagues on a global level to bring forth our policy agenda and come together to really shape the world. You know, every Minister of Health is there, so it's just such a wonderful and great energy. So I'm excited for those who will be able to join us, and for those who aren't, hopefully you can join us online for a few things. So Living Goods is a nonprofit organization. We work primarily in East Africa on strengthening the primary healthcare system and specifically looking at community health systems. So we feel like community health fits in and many times left out of the primary health system. And we think that it's such an important piece of it to ensure that everyone has access to health, thereby getting to the definition of universal health coverage. So for us, we think it's extremely important that not only is the health system complete, strong, and gets to all the people who need it, but it's also funding. And today's conversation talks a lot about how that funding will happen. Living Goods is working in their 2.0 scale, which started in late 2017. We're focused a lot of efforts on advocacy at the global, national, and subnational level in many countries. And with that, we're focusing on how that is financed, setting up finance accounts and working with local governments to ensure that once the accounts are there, that the funding actually flows. So working, in partnership with things that are happening at the global scale. Next slide. So before we kick off into all of these things about universal health coverage and financing, we wanted to take a step back and talk a little bit about what is UHC. So we have a little bit of a quiz for you to make sure everyone's still awake, paying attention. So first, what does universal health coverage really mean? Go ahead and click on your answer. All right, I think we have enough time there. And if you chose all of the above, you were correct. It really does mean all of the above. And we wanted to make sure everyone got that. Oh, well, not everyone, but mostly everyone got that. And the reason why it's important is because we want to make sure that we're talking about all of the pieces of UHC. It's not only about the funding piece of it, but it's making sure people have the access to quality healthcare. It doesn't mean that everyone is going to have free healthcare, but it means that most of the process in the system won't be out of pocket. And then we want to make sure that it's available for individuals as well as the broader population. So how much of the world's population is not able to obtain health services that they need now? Great, let's see how you answered. And it looks like they said at least 70%. Well, according to the WHO, they said at least 50% of the world's population. But we definitely know that in some of those smaller areas or rural areas outside of the capital, many times that number is much, much higher. Next one on our final question. Globally, about 100 million people are being pushed into extreme poverty, living on $1.90 or less a day because we have to pay for healthcare services. Is that true or false? All right, let's see how you answered. That is true. You're correct. Yes, and that's a big part of the problem. So, today we're talking about the health system and making sure it is strong enough, and we're putting money and resources and and time, energy, and effort into planning it out and making it look like what it needs to look like, so that when we put the resources into it, it actually can sustain, not only for preventing epidemics, but also to reach the people who need it, and it will reduce the out-of-pocket costs. So all of these things must come together. So looking at the pathways to UHC, we already know that more than 100 countries are on this pathway. But as you can tell, that getting to that pathway is just not one step. And for many, many countries, this requires a lot. They'll spend a lot of time at different levels. These are just some of the things that they need to put in place to get to the goal of quality healthcare for all. So they need to talk about redesigning their health system. You can't just keep putting a Band-Aid over a broken system. And we know that. We know that if the system never reaches, or you're just putting new hospitals in the capital, you're never reaching those people outside of the major areas, then you're still going to have a separation in services. You're still going to have high maternal mortality and infant mortality in areas where, frankly, it should not be. But you have to redesign a health system. You also have to focus in on the community health system and make sure that it's attached and that referral systems are in place. Community health workers in your health workforce, which is another item here, are trained, supervised, supported, and paid. Our goal is to get them paid and get some value for the work that they do. Also diversify the funding. You know, we'll spend a little bit more time talking about later, but that is a key part of it. We've been for years saying that you can't rely just on donor funding, and you know, this is really coming closer and closer to fruition as one of the largest donors in the world. As you know, every year we've struggled with meeting those deliverables and certainly coming short of what the world needs. But this is even more important as we get more people are born every day, and that the system has additional strains on it. And finally, stronger integrated health systems. Again, that's getting to the point of a health system, back one side, a health system that is strong and integrated, which will have all the pieces in place, including the financing, including the health service delivery. All those models are going together, and that the models are not pieces pulled apart. That will get us to the quality healthcare for all. Next slide. So a quick review and basics around innovative financing. So essentially, there is no one way to think about innovative financing. Essentially, it comes down to what we're doing differently from the traditional donor model of just receiving funds for your health system. In the 2030 Sustainable Development Agenda, we all know that the United Nations put forth this course to end poverty, protect the planet, ensure health and prosperity for all, which we all agree is wonderful, but that means that it's also a higher goal to reach than it has been before. In order to drive forth, we've estimated that a $2.5 trillion in funding will be needed each year to achieve these goals. And basically, it comes down to where's this money going to come from? So innovative financing refers to the various plans outside of the traditional donor model for funding. One thing we know for sure is that there is no one-size-fits-all model for innovative financing, as there's no one-size-fits-all model for UHC. And countries are going to have to figure out the best plans. So one of the things that will particularly come out during the WHA and the lead up to WHA is what are countries doing specifically? So last year, it was a lot of talk around UHC. This is our plan. This is our goal. This is our, North Star. Now, over the last year, countries have, at different levels of success, have really put pen to paper and looked at their country plans and figured out what donor funding they already receive, how to leverage that with other ideas, and bring together diverse partners, which include people like us, civil society groups globally as well as locally in country, to figure out and help them figure through plans and make sure that those plans do not stop just at one disease or one issue, and that really go down to all levels of the health system. We know that achievement of UHC is complex and requires different sectors. We know that you're no longer just talking about health. When you're talking about improving health, you have to talk about education and you have to talk about jobs, because all of those link together. It offers financial protection on different items. So those are some of the things that we're talking about a bit more. So you have ministers of finance talking to ministers of education, talking to ministers of health, and talking about how you can shared resources can pull some things together. And it's not just about financing or costs, it's about also the quality. So with the resources coming through for financing, you'll have different ideas coming forth of improving quality and improving quality, reducing the cost that we now just pour into a weak system. So a couple of things that I wanted to bring out, this is certainly not an exhaustive list, but they tend to be the more popular financing models. Shared risk and pooling of funds through insurance. You'll hear that some countries really are looking into insurance schemes. And when we started talking about financing for UHC, quite a number of people instantly went to insurance and thought that was going to be the answer. The reality is in most countries, it's going to be a combination. There are definitely going to be a population where insurance will make sense, similar to what we do in the US, where a lot of people's health coverage is done through their workplace or some sort of insurance model. Leveraging health benefits from investment in other sectors. I touched on that a little bit. So getting kind of the runoff. This was a bit about what Rwanda did in their system when they set up their country plan. Is kind of getting investments made and freeing up dollars for other things. So they got people to invest in the areas that may be more profitable or seen as more interesting to invest in, and then they freed up their own domestic funds for health or did shared investments. Strategic purchasing and results-based financing. This is one of the things that Living Goods is quite interested in and working a bit more on this results-based financing, but particularly at the community level. Traditionally under UHC, it stops at the national level or it stops at the facility level. What we're trying to do is get it below that next level, particularly for supply chain management. Global health initiatives and innovative financing. We know that these are the things that we hear about a lot for GFF and other different financing groups coming together, World Bank, and we'll talk a little bit about these later, but these groups coming together and saying, how do we pool some financing and these initiatives together to create financing? Universal access to family planning and all of these different approaches were done because they're trying to pool resources together where that is strength in numbers. And then, of course, our traditional public-private partnerships that will always continue to exist. Privatized healthcare is pretty high in most low-income countries, and so that will probably not change because usually the quality is better in the private sector. But finding some sort of balance in that initiative so that people who can afford to pay and people who can't afford to pay are still getting good quality. But it may be that, in a country, the government may decide that they're going to let a private organization come in and help improve a government-run hospital so that the quality can improve so that people can go to both. You still have both options there, and this is, a little bit more common in a place like South Africa where your quality is still there, but you're elevating the quality in both places. Next slide. Finding the right pieces for the puzzle. So as I mentioned, there's just no one way to do it. So we've been doing traditional donor funding. It's never going to go away. I mean, it's going to be needed. You still have countries, which I think does feel like a rage of panic, and countries where it's really, really difficult, like a South Sudan. I mean, if there's no donor funding in there, overnight, are they really going to have a new health system that's going to function and give the quality of care that it needs? Probably not. It's going to take quite a bit of time before they are moving into any UHC model. But what we're saying is we need to get and start moving quickly into some sort of hybrid models. And so you'll see a lot of trying out different methods. So you'll see blended financing, performance-based financing, domestic resource mobilization. These are all different hybrid models of taking things that the donor funding is still existing in countries, but they're also figuring out other ways to bring in resources. And then the idea is that all these pieces together will form UHC, and recognizing that UHC is going to look different in a Rwanda or a Kenya than a Ghana or South Sudan or an Afghanistan, but our goal is for all of the countries to get there. We do know that governments are partnering with private sectors for innovative mechanisms that will continue. They have some matching grants going on. Another big thing that's come out quite a bit recently is using charitable funding to attract private funds to development projects. So you'll have things, the idea is getting away from funding a hospital maybe and funding a community health system in a country. So you're seeing a pivot a bit in those blended financing, and of course social impact bonds, bringing in private financing largely from outcome payers is also coming up quite a bit, and there's still a lot of talk around it and not huge amounts of evidence yet of where it's worked at scale, but the fact that the conversations are happening is really the right direction for us to move to UHC. Next slide. So I wanted to talk about a couple of ways that leading up to WHA of ways that financing is coming together. So right now, right in Denmark, they are having a global dialogue on sustainable financing for NCDs. And so again, this is what we're talking about is you're having an interest in figuring out financing for different health issues, whereas an NCDs is a bit different than something like a HIV because NCDs encompasses so many different health risks. And we also believe that one is the largest issue happening in countries because it includes traffic accidents or road accidents and all those things. But it's also something that countries have identified is a tremendous burden on their health system. And so the same way there was a lot of resources, a lot of function on financing HIV, which strengthened the overall health system, we want to make sure that these other platforms and financing mechanisms are also thinking with that forward thought. If you do create these sustainable financing on the side, you have to make sure, again, that it's not so limited that it does not support the whole health system. And then the other meeting that will happen later this month in April will be the 3rd annual UHC Financing Forum, again, getting to equity. And that conversation is always unique because it's a lot more ministers of finance who participate. And so you hear what their concerns are. And last year, one of the big things they talked about is, can you wrap this in how we get better jobs? And so as advocates and those working in this field, we have to figure out and make sure that we are figuring out how health and getting to our UHC goals also connects to our economic goals. Next slide. And finally, in Geneva, a group of partners, including Global Health Council, the Frontline Health Workers Coalition, IntraHealth International, and Living Goods will be having a conversation on diverse pathways and partnerships to universal health coverage at the Geneva Press Club over breakfast, Thursday, May 24th. Food is included. It will be webcast. And the things that we're really focusing in on are these specific examples. So some of the things that I brought up today from innovative financing interventions, we're talking about ones that are working in a couple of key countries and what we should be looking out for. And we try to pick countries where we know a number of diverse partners are working in, so we can all be aware of these things and participate in. Coalitions at the country level sometimes are not as robust as maybe they are here, and different people hear different things. So it's a really great opportunity to share what is happening, what's moving forward. We also want to talk about collaborations with donors, investors, and governments, because a lot of moving targets are happening, and then talk about what's really happening with domestic resource mobilization. I know, like I mentioned, Living Goods is really working at that subnational level to work with partners on the ground to create those same type of work groups that we have here in the US to advocate to Congress for funding, to do that at that level. So it would be great to have other partners come together and do that. So we really see that as going to be a conversation and a working session of which we really are going to come out with some outcomes and some move our conversation forward. So that's it for me. I'll turn it back over to you, Lois.
Great, Crystal. Thank you very much. Now is the time for folks to weigh in with their questions for each of the speakers, Ashley or Crystal, on their topics, global health security or universal health coverage. Again, go ahead and insert your questions into the chat box to the right of your screen. We did get at least one in that I'm going to reframe a bit, because what we received was in relation to someone who is thinking about working in this field and wanted to get a sense of the ideal background, in particular for UHC. But I think, Crystal, this lends itself to a different kind of question, which speaks to the types of players that should be at the table for UHC. Can you speak to sort of the type of health stakeholders that are being called to the table to figure out this issue, but even other stakeholders outside of health who are around the table for this type of discussion?
Yeah, great point. I think that, and traditionally we've always said, okay, you work, the health folks, let's get around the table, let's talk about UHC. But I think the way the SDGs were written, as well as, frankly, the resources that are available, to make the bigger impact, we're going to have to make more of a shared discussion and shared coalition. It doesn't mean that you're watering down any one issue, but recognizing, and it always gives me the example of countries that said, no one wants to pay for roads, but roads have to be paved so that you can get people to health facilities. So how do you get roads paved is you maybe put a little piece of roads in everybody's budget, and bringing that through. But that also means that you're having a conversation with maybe the Minister of Infrastructure, or you're talking to those who work in the hospital, but building, maybe on the building team, to figure out and help them understand why, people aren't using your facility is not a good thing if people cannot get there. And so how to work together. So I think when we're talking about more of the civil society side, that it's really important that we think a little differently than we may have done traditionally. And that's frankly, to me, what innovative financing is all about, thinking out of the box. How can we do these things differently so that we make an impact? And that means having different voices. It may be you're not even a health person. A lot of the people at Living Good, for example, came from the private sector, more of a business side hat to it. Now, of course, it's partnered with good public health, but they bring in different avenues and thoughts around how to make an impact and how to make change.
Thanks, Crystal. I think that's helpful. There's some other questions that have now come in. I'll go ahead and skip to Ashley and then come back to Crystal for additional ones on UHC. But a couple that have come in around global health security and the global health security agenda. One is from Okelo Luanga, who wanted to know which countries have signed on to the GHSA so far. And I believe that list is fairly extensive, so feel free to provide a few examples and then perhaps a link to find more information, Ashley. And then there is another question on global health security from Marlene Velicoop, who asked about sort of cross-border sharing of surveillance data and how that could be improved. So first off, who signed on to the GHSA, and then next, this idea of how countries, especially those that have signed on presumably, can coordinate their efforts, particularly their data efforts.
So great, thank you for these questions. They're really fantastic. I said that there's 69 countries that have voluntarily signed up to undergo a joint external evaluation and do the planning process. So I won't list them all, but I'll give you an illustrative example. We have countries from Afghanistan, Argentina, Bangladesh, Burkina Faso, Cameroon, Canada, the US, Ethiopia, Finland, France, Georgia, Mexico, Mali, Malaysia, Sweden, Spain, South Africa, Singapore, Sierra Leone, Saudi Arabia, Zimbabwe, the UK, the UAE, Turkey, Norway, Philippines, Korea. So you'll see that it's a really interesting mix of Latin and South American countries, African countries, Global South, and Asian countries, as well as Scandinavian countries, the US, UK. The US actually underwent one of the first assessments. This is before they were called joint external evaluations. All of the results from these joint external evaluations are freely available online, which makes it really interesting and a different way to have accountability for these countries. If you understand that a lot of countries wouldn't necessarily want to show where they have weaknesses in their infrastructure, especially around infectious diseases, the amount of transparency in the agenda is truly inspiring. Now the second question, and I can of course provide links on what countries and where they are in the planning process, and also so you can see results about where each country measures and falls along that line of unreadiness to fully prepared. Now the question of cross-border surveillance really speaks back to that whole, we're living in an interconnected world. Viruses don't need passports to cross into different countries. As we saw in the Ebola spread, that it pass freely from, Guinea, Sierra Leone, Liberia, Guinea-Bissau. What we're trying to do, and what the GHSA, I think, is an area that still needs to be a little bit more thought put into, is how we best share those lessons learned of if a country can improve its surveillance and ways that a country has invested in order to do so. So that's one of the areas of focus moving forward, is that issue of that transparency and data sharing and lessons learned. There are some websites, and the WHO has what's called a strategic partnership portal that hopefully will be a repository of data and the ability to grow from those programs that have succeeded elsewhere.
Great, thanks very much, Ashley. Appreciate that. We have an additional question from Laura, our friend at IntraHealth, and she had a question on UHC in particular. She was wondering, in addition to sort of what we've heard today about how we advocate for UHC, she wanted to know what role global health and development partners play in supporting countries to implement policies that promote UHC on the ground. And so it seems as though she might be making a distinction between sort of how we're advocating, for example, at WHA, and then specifically what we can do at the country level or at the national level to support policies that advance UHC.
Yeah, and Laura, I think you're absolutely right. We have to do both. Like, we really have to do both. And I think it's always going to have to be a two strategy of, you know, in Geneva, everyone maybe says the right things, or in other donor meetings, people say the right things, and then you don't see it actually come to fruition at the country level. And I'll give an example of the work that Living Goods is doing in Kenya. So we are looking at, Kenya is very decentralized, as many of you know, looking at county by county. And because they're decentralized, going to the Ministry of Health he's at the end of the decision-making process. It really is the counties that are making the decision about funding. Some of them may never know about what was said at a meeting in Geneva. But what we have to do is constantly educate and bring that information forward and work with them. Some counties have already decided that they're putting money into certain things, and the same way we have to do things at the state level in the US and then at the national level, we still are responsible for doing both. And I think it's important. Many of us work in countries and have local offices and our partners and all of that we work with in country. And I think it's important that we're not keeping this information at this global level, and it never meets down to the people, frankly, who are on the ground, who may be the most affected, but also the people who have the decision-making ability, particularly as it speaks to financing health.
And Crystal, thanks for that response to Laura. Can you also answer a follow-up question from Idrissa So about the role of community in UHC, not only as a passive beneficiary, but presumably as sort of an active kind of advocate or participant in that process that you were describing?
Yeah, and so, and that's a big part of like what we're interested in. The community and the community health system has kind of been left out of most of the conversation. So you don't see, so usually the conversation seems to stop at facility levels. And we know that that doesn't always include, the facilities are done by the government, which is great, that's what they're supposed to do. But that community people and the community health system are a big part of the need. So if you have a community health system that the closest clinic is even that offer all free services and actually has supplies included, still may not be accessing those supplies for a specific reason. And so the community has to be involved and engaged. And I think for those of us who are working at the country level, that we're making sure that we're partnering together and supporting one another in those efforts, those coalitions, we recognize how powerful they are here. And sometimes I don't think we always recognize how powerful they are at country level, because we can share information about what's happening. And so that communities know, here's the timeline for things happening. This is where you can be making an impact. Did you know that your government, actually your county government, has actually allocated funding for health in your local community, but the money hasn't been moved over because no one's actually called them on it? So all of that little stuff the community has to know, and not to say that they don't always know, but they have to be supported when they are advocating, and that we have to support those efforts just as much as speaking with the Ministry of Health, because the ministry can hold them accountable, but a lot of the other things I think are happening outside of that ministry, being more of the capital ministry versus at the local levels of the ministry. So the community as a people are extremely important. Many times they are, hopefully, included in, and I think the processes have gotten better with including them in on the strategy and the planning. But beyond the strategy and planning now, it's like, where's the money? Where's the backup for these things? What's the timeline to get these things funded in my local community?
Mm-hmm. Great. Now, Ashley, Idrissa also wondered how One Health coordination actually works at the country level based on your experience. We have an additional question from Laura Altobelli, also who wanted to know whether or not climate change was considered in this sort of One Health framework and as part of the work of GHSA.
So those are fantastic questions. So the One Health coordination is definitely an area that still needs to be improved upon. I don't think that there's a real understanding at a lot of levels about how animal health is essentially human health, when 70% of diseases have the ability to sicken or infect human populations. And what the agenda has tried to do through incorporating things like FAO and OIE has really provided that voice and that awareness at the global level. Now, at the country level, one of the outcomes of the past year that the USG has helped sponsored are the launch of One Health platforms. They're not active in all countries yet, but they are starting. And I can provide a list of countries that have an established One Health platform. Also, some of USAID's programs through that emerging pandemic threats program, where DAI is the lead, I think it's called Prepare and Respond, excuse me, has worked to establish those One Health coordination platforms so that animal health and human health experts can come together and share information, knowledge, and through coordination efforts. The question about climate change, I think that there's a general awareness that climate change is contributing to the rise of some infectious diseases. I think we saw a real impact of that through the Zika outbreak in our southern states and Latin America, and the spread of mosquitoes further north than they had really ever been before. And that can be drawn back to changes or warmer weather in more northern climes. It's hard to get everything under this one umbrella. So I think that while there is a general awareness, I'm not sure beyond information sharing and some general coordination, there's no action package around climate change and how to combat that for infectious disease.
Thanks for that, Ashley. We did have a couple more questions, but in the interest of time, I will at least credit those who have submitted them and even maybe turn them into recommendations for our speakers. We actually had one more in the form of a comment from Mustafa Al-Arab, who was just offering his take on how UHC recommendations could be framed in terms of kind of the goals that we should set for governments regarding their financing, their monitoring, and inclusion of NGO services. And so I think that point will be well received. Mustafa, thank you for submitting that. Also, Yanira Garcia had a question just around getting beyond infectious diseases in the framework for how we talk about global health security, and really getting more into equitable access to healthcare services and public health. And also taking into consideration social determinants. And so I think that's a really valid point, is sort of whenever we're talking about these issues, remembering the full global health spectrum and, you know, all of our respective training in public health, in particular, kind of what sort of puts people at risk for poor outcomes, whatever the cause or situation. And so begging forgiveness for those of you who had some questions come in a bit later. I will go ahead and transition to Liz to close us out today, just to provide some additional information on upcoming webinars. Again, these slides and the recording, I think, will be shared with everyone who's registered following following us closing out, and we might have the opportunity also to send responses to final questions from the speakers after the webinar as well. So Liz, over to you. Thanks, everyone.
Great, thanks so much, Lois. Yes, I just wanted to provide a couple quick next steps for everyone. As we mentioned at the beginning of the webinar, this Scrum is actually part of a series. The next WHA policy Scrum will take place in 2 weeks on Tuesday, April 24th, again at the same time, 2 p.m. Eastern. And that Scrum will actually focus on creating and building policies and programs that focus on multiple health issues. And we're going to focus specifically on NCDs, or non-communicable diseases, and tuberculosis. Those are two health issues that are going to be elevated this year at the UN General Assembly. And we will actually also be hosting an event at WHA on this very topic. And again, as a reminder, WHA is coming up at the end of May. GHC is sending a delegation of our members to WHA. More information on our delegation, along with other information on hotel room blocks, our calendar of side events, and more can be found again on this webpage, globalhealth.org/WHA71. Again, this link will be in the presentation, and we'll send out the presentation in a couple days along with the recording, which you can review again or share with your colleagues. Last but not least, like I said, we are populating a side event calendar on our website. So if you or your organization is hosting or co-hosting a side event at WHA, we encourage you to share invitations to events at globalhealth.org so we can put it on our calendar. And again, there is the link for you to access the calendar to plan your own schedule at WHA. And with that, I just want to thank again our speakers and everyone who attended today. We hope that you join us in a couple weeks.
Thanks, everyone. Thank you, Liz. Thank you, Crystal and Ashley.